I'd like to introduce you to Dr. Jay Andersen, who will be presenting on hormone therapy, the basics and beyond. In this session, he will review standards of care and recently evolving antihormonal treatment, as well as treatment options for hormone receptor-positive metastatic breast cancer. Dr. Andersen received his medical degree and completed his internship, residency, and fellowship at the University of Kansas. He's board certified in oncology and hematology, as well as internal medicine. Dr. Andersen is a co-director of Compass Breast Specialists, a division of Compass Oncology that provides comprehensive services and treatment for breast cancer, as well as high-risk and complex breast issues. He's recognized as a leader in the field of breast cancer and serves as a member of the National Breast Research Committee for U.S. Oncology Research. He is a principal investigator of breast cancer clinical trials for Compass Oncology. Dr. Andersen has presented at international conferences such as the San Antonio Breast Cancer Symposium, which provides state-of-the-art information on the experimental biology, etiology, prevention, diagnosis, and therapy of breast cancer and premalignant breast disease to an international audience of academic and private physicians and researchers. He's renowned for his many publications and presentations. Dr. Andersen is involved with many different organizations, which include, but are not limited to, sitting on the Education Committee for the Komen, Oregon chapter, the Scientific Advisory Board for Consano, and he's an active member of the Providence Hospital Breast Leadership Committee. In clinic, he is well known for his caring and informative approach. His patients love his detailed explanations, his handouts and diagrams that ensure their complete understanding of their diagnosis. And he is one of those docs who, with a very busy schedule, is actually on time. And now, without further ado, please help join me in welcoming Dr. Jay Andersen.
Thank you, Jen. It's always a pleasure to speak at this event, and I appreciate the people who are on the webcast. It's always empowering because you all choose to be here, and data show that if you're engaged in your care, outcomes are better. So kudos to all of you to engage in your care. Full disclosure, I changed the title a little bit. So originally I was going to speak only about hormone receptor-positive breast cancer, but as my slides developed, I realized there's several new exciting developments outside of the ER sphere, but still have overlay and concepts. So we're going to cover more of a generalized conversation about new evolving targeted therapies. I show this slide at almost every talk. I think it's very powerful and simple. This shows that the incidence of breast cancer is 1 in 8. So this woman here is a survivor. She's had bilateral mastectomies, and she developed or gathered 7 family and friends to take the photo simply to show 1 in 8, or 13% of women will develop breast cancer in their lifetime. So imagine the impact on the family, on the society, in the workplace. So everyone eventually is affected in some way, shape, or form. Breast cancer used to be just breast cancer decades ago. And now, over time, we've evolved into some general subtypes of breast cancer. Hormone receptor positive is about 3/4 of breast cancers. HER2 positive breast cancer is around 20%, and triple negative is around 15 to 20%. But that landscape of nomenclature is rapidly changing. We've known that if we can name a feature of the tumor that has clinical relevance, and typically that gives us more information regarding prognosis, then we can develop a therapy that may target that particular target. So in the hormone receptor-positive realm, we have hormone therapies that we don't really think of being targeted, but they are. They target a particular receptor and have a particular impact. So that's kind of an old school targeted therapy. And then, sorry, I keep pushing the wrong button. Then HER2 positive, we also have targeted therapies as well. But the landscape, as I referenced, is rapidly changing. As you can see here, the overlays of how we're starting to subtype certain types of breast cancer and develop additional therapies that target those particular subtypes. So a theme we're going to discuss is a growth pathway. I always explain to my patients, think of it as a fertilizer pathway that causes your particular tumor to grow. And to review kind of the basic concepts of that, this is the fertilizer pathway of the hormone receptor pathway. So here is the hormone receptor, here, estrogen receptor, and the estrogen molecule can bind to that and then speak to the DNA and tell the cell to grow. By the way, we have a double pointer here because the people who are on simulcast can't see my pointer, so the arrow is following my pointer, so I apologize if that makes you dizzy. So I'll try to not excessively point. So that's the concept of a targeted pathway, meaning that pathway in a hormone receptor-positive breast cancer is driven by hormone exposure. We like to think we're smart, though. We think, oh, we discovered a pathway, and therefore, if we block it, then it'll solve everything. But we know it's much more complicated than that. It is not just a simple one-way street. It's probably more something like a complicated highway system. We've seen this in the clinic and in the lab. You block a pathway, the tumor then exits and goes on an off-ramp and develops growth pathways alternate to that. So that's why it can be very complicated. And as we evolve, we need to identify and understand that there's a communication between this complex network of pathways, and that then becomes more complicated as we try to understand and interpret every particular tumor and how it may behave. I like this analogy because we all kind of relate to this. I think we all remember the book Horton Hears a Who. And in Horton Hears a Who, Horton identifies a city on a speck of dust. So in that speck of dust is a complicated city, kind of like a tumor cell has this inside of it. And it's extremely complicated. I always get comments from survivors or non-medical people who say, haven't you figured this out yet? Why is it so complicated? That is why it's complicated. You may understand one element of a pathway, and then you may block that effectively, but then there can be intercommunications and further expressions of other pathways that then kind of derail your simple pathway blockade. The better we can define the tumor, then we can develop targeted therapeutics. So again, the name game becomes more complicated. It used to just be breast cancer. Then it was hormone receptor versus not. Then HER2 positive. And now we're subdividing that even more so. And this is a very oversimplified list of those subdivisions. People may have heard about luminal A and luminal B in the sphere of hormone receptor positive breast cancer. We have HER2 positivity. We have triple negative. Someday we won't call it triple negative. We call it triple negative because it's ER negative, PR negative, HER2 negative. But what is it positive for? We call it triple negative by default, which means we don't have a targeted therapy for it yet. Someday we'll call it something else. We'll say it's XYZ positive, and then we'll have a therapy that targets that pathway. So unfortunately for now, that is a default term, which means that we have not identified a targeted biomarker, but stay tuned. We're going to talk about PD-L1 data, and that is relevant to the triple negative subtype. And then BRCA positive, which is a genomic mutation, a hereditary genetic mutation, and that also may serve to guide us in how we develop therapeutics as well. But the point being is the better we can name, the better we can target. The whole purpose of naming is to provide information as it relates to prognosis and how we can develop therapeutic strategies. So look at the list now becoming very complicated. Old school hormone therapy, still very effective. We're going to talk about partners that may go along with that, which are listed down here. HER2-directed therapies, rapid changes in that sphere as well that we're going to discuss. Old school chemotherapy, we still have it, we still use it, we're using less of it, we're learning how to better use it or minimize use of it or de-escalate utilization. We're going to talk about these evolving targeted therapies, immunotherapy, Parp inhibitors, and a laundry list, so it's really complicated but super exciting. As I've said, the better we can clarify and name the cancer and predict how it may behave, we can then offer information as it relates to prognosis. How is this tumor going to behave? And therefore, how is it optimally treated? And how can we then develop appropriate therapies that target that particular tumor? So today, it's going to be a whirlwind. Jen's going to hold up cards when my time is running out. But it's going to be a good whirlwind because we're going to cover a ton of exciting data. So we're going to talk about hormone partners and their evolution. We're going to talk about updated data in the HER2 positive sphere and this exciting data out of San Antonio using immunotherapy for triple negative breast cancer. Again, it may not be called triple negative any longer. And then Parp inhibitors, a quick reference to that, and also a quick reference to the androgen receptor, which we occasionally hear about. and has not really found its exact niche yet. The first topic is Cdk4 Six Inhibitors. I remember when this was first brought up at San Antonio several years ago, I had to go back and read my med school book. I was like, what is a Cdk4 Six inhibitor? And what the Cdk4 Six apparatus is, I have a picture to show you. It's an apparatus that when active, it allows the cell to go through the normal cell cycle. I have a picture to show this. So think of this as another pathway that permits the cell to grow and develop that then we have the chance to maybe block. So the question at hand, or already has been at hand and drugs have been developed, is if we're aware of that pathway taking place concurrently with the hormone pathway, what if we develop a Cdk4 Six inhibitor and pair it with a hormone agent, and will we have improved outcomes? One comment I want to make is sometimes when things sound really logical, like that sounds logical, I'll show you a picture and you say, of course that's going to work. And actually it did work in this case. But sometimes we have examples over decades of research where we think something sounds very plausible, biologically sound, it has to work. You do a trial and it does not work. Maybe there were reasons why the trial was not designed appropriately or optimally, or maybe that biology or that assumption was simply incorrect. So we always have to prove a concept in a trial before we can actually engage and follow and believe in it. So here is that, what I was referring to. Remember 8th grade biology, mitosis, cell division. Remember that? So there's a cell cycle, and the cell has to pass through phases called G1, S phase, G2, and then it can divide through mitosis. So the concept is, we know that in order to pass through G1 effectively, the Cdk4 Six apparatus has to be appropriately activated and engaged. So the concept is, what if we develop a Cdk4 Six inhibitor, and that would then result in G1 arrest? It would stop here, which is a good thing if you're trying to stop growth of a hyperactive tumor clone. Remember, a tumor is simply a set of cells that has a mixed message, a wrong message. Instead of grow, grow, die, like a normal cell, it grows and grows rapidly and can spread. So you're going to capitalize on the notion that these cells are growing more rapidly than normal cells. So if you can induce a G1 arrest in that rapid clone and maybe pair it with hormone blockade, hence a dual pathway of blockade, maybe outcomes would be better. Sounds totally biologically plausible. So let's see what happened. Here's another picture that simply shows that we're going to take a dual blockade of the hormone pathway with appropriate estrogen blockade with a variety of options, and we're going to pair it with a developing Cdk4 Six inhibitor and see if we can improve outcomes. And that occurred. 3 Cdk4 Six inhibitors are available. They are listed here. Trade names are Ibrance, Kisqali, and Verzenio. And through trials known as the Paloma series, Mona Lisa series, and Monarch series, those trials all showed in the stage 4 setting that if you pair one of those with a hormone therapy, that you improve outcomes dramatically. Across the board, kind of averaging out the trial outcomes, the progression-free survival, let me define what that means. That means this is stage 4, remember, so these are patients who have tumor elsewhere in their body that is not curable, that we can scan and we can see. Now we're going to start a new therapy, and we're going to follow them with scans until that therapy no longer is effective. In other words, there's tumor growth. We call that interval progression-free survival, or absence of progression, patient is still living, okay? We call that PFS. That's an endpoint we use in a lot of trials. And what they showed in all those trials is that PFS improved from, on average, 10 to 15 months if you take a hormone therapy only, which at the time was the current standard of care, to nearly doubling to 20 to 25 months. That's huge. In oncology, we get excited when a new drug improves outcomes by 2 to 3 months, sadly, in some trials, but those are small inroads sometimes we observe. This was a huge inroad. So imagine in the first or even second line setting with hormone therapy, you're nearly doubling the PFS. So we're changing the landscape of stage 4 breast cancer, especially hormone receptor positive. In general, is it curable? We tell patients it's not curable, but the landscape is dramatically changing. If we're nearly doubling PFS with only the first-line option, we have second line, third line. We can move down the road eventually. We typically will use chemotherapy in these patients, but if we can add to all those incremental gains along the way, we improve overall outcome. These are all oral agents that are largely well-tolerated. The main thing we have to monitor is the white blood cell count. It can drop the white blood cell count, then you have to dose adjust appropriately, but largely well-tolerated. The general mantra in medical oncology is if something works in the stage 4 setting, maybe we should try it in early stage, and that's how it normally works. And this is what is now being done with the Cdk4 Six Inhibitors. They're being investigated in the early stage setting in what is defined in each trial as higher risk hormone receptor-positive breast cancer patients. So normally those patients may receive chemotherapy if it's indicated, then they go on hormone therapy for 5 or more years. That's a different talk. In select higher risk patients who are eligible for a trial, we may offer them pairing. It's a randomization between you get a Cdk4 Six inhibitor or not in combination with your standard hormone therapy. And the goal is to follow those patients, and I think all the trials are for 2 years. The Cdk4 Six inhibitors for 2 years, the hormone therapy is for 5 or beyond. And the goal is to see, can we reduce the odds of recurrence? And stay tuned. Those patients are now being enrolled. We're following the outcomes. There's no mature data yet. And we're also looking at even preoperative trial exposure as well. So that's the overview of the Cdk4 Six space. Very exciting, rapidly changing, and being explored in early stage as well. Next topic is the PI3 kinase AKT Mtor pathway. Back to that complex highway system. This is another pathway that has been identified as being a main driver in breast cancer and thus is potentially targetable. Here it is, kind of complicated. But the players that we think of as the critical stepping stones along the pathway, so once there is a factor that may activate the pathway, the key players are PI3 kinase, AKT, and Mtor. And we know that if you effectively go down that cascade, it then leads to cell growth and proliferation and tumor spread. So again, the theme of targeting a pathway, can we develop targeted agents that may block the PI3 kinase, AKT, or Mtor pathways? And again, that same concept. What if we pair a standard hormone agent with another partner? So we're offering a dual blockade. Would that improve outcomes? And one drug is already approved. It's an Mtor inhibitor called everolimus or Affinitor, and it's based upon the notion that we know that the Mtor pathway is an activated pathway in breast cancer, and up to 70% of breast cancers have changes or mutations in the Mtor pathway. So it makes sense. Maybe we should block that pathway, pair it with a blockade of hormone therapy, and see if we improve outcomes. And this kind of shows that pairing right here. In this case, it was paired with exemestane, otherwise known as aromasin, which is one of the standard aromatase inhibitors we use. So here it shows exemestane being paired with Affinitor, everolimus, the oral Mtor inhibitor, as the general concept. And the data were published in the Bolero-2 trial in the New England Journal of Medicine, showing that we improve outcomes. We see an improvement in tumor shrinkage from 26% to 51% simply by adding the partner agent. And it doubled the progression-free survival again. In this trial, the PFS was a little bit lower based upon the patient demographic, but nonetheless, we see a more than doubling from 3.2 months to 7.8. So Affinitor everolimus is available. Those data, I think, were from 2012. I just gave that for historic reference, so we'll get to a slide in a few minutes that kind of asks the question, how do we sequence? What do we do with all these therapies? How do we select what we pair and when? So embedded in that pathway was that PI3 kinase stepping stone. And we know that the PI3 kinase pathway, which I kind of alluded to as it relates to Mtor, is frequently altered in hormone receptor-positive breast cancer and is implicated in hormone endocrine resistance, 40% of breast cancers, hormone receptor-positive breast cancers, will have a PIK3CA mutation. That's a mutation in the PI3 kinase stepping stone, leading to hyperactivation of that pathway. So again, biologically sound question. What if we block that stepping stone, pair it with hormone therapy? Would that improve outcomes? And this is new data from San Antonio in December. By the way, San Antonio, I refer to that, that's the world's largest breast cancer conference held annually in San Antonio every December. So the SOLAR-1 trial data was presented at San Antonio just in December, and it asked the question, again, you're hearing a common theme here, hormone therapy versus hormone therapy in combination with a PI3 kinase inhibitor called alpelisib, which is an oral PI3 kinase inhibitor, asking the same general question. If you pair that blockade agent with standard hormone therapy, will outcomes be improved? In the SOLAR trial, they paired it with fulvestrant, otherwise known as Faslodex, which is an intramuscular injection. It's a standard hormone therapy that we use in stage 4 disease. What they did in the trial is they specifically looked at data outcomes as it relates to a mutation in that PIK3CA gene. So they allowed people who had the gene mutation or not to be in the trial, but then they analyzed the data in those two subgroups. And what they showed was there was benefit to the combination if the tumor was a PIK3CA mutant. So that becomes now clinically relevant. We're going to now be asking the question, should we be running a PIK3CA mutation analysis on the tumor? And if so, now then, not yet approved, but stay tuned, could we then add a PI3 kinase, alpelisib, in combination with fulvestrant and improve outcomes based upon the SOLAR data, which showed we improve the PFS from 5.7 months to 11 months. Again, all these partners are kind of showing a doubling or so impact. So this is what I was referring to when we talk about topics like this at tumor boards all the time. It's like, what do we do? What do we start with? How do we sequence? When do we partner? And we have some guidelines, but there are still some gray zones that we're not quite sure exactly how to proceed. But I'd say one general strategy that's typically used, and again, we're talking about hormone receptor-positive stage 4 breast cancer, is typically we start with hormone therapy, pick the hormone therapy, an aromatase inhibitor, maybe Faslodex, maybe tamoxifen if the patient's premenopausal, with ovarian suppression, for example. So hormone therapy in combination with a Cdk4 Six Inhibitor. Based upon the trial data I showed you, that nearly doubles the PFS, 10 to 15 months, 20 to 25. So that should now be a standard. Is everyone receiving that? No. I give talks around the country, and I'm surprised when I hear references to doctors only giving patients hormone therapy first line. There should be rare exceptions that may support that, but largely, patients should be offered and be pursuing the combination. It's well tolerated, and it doubles outcomes. Eventually, based upon those trials, the PFS being around 25 months, that combination may fail to be effective. So what do you do next? One option would be that everolimus Afinitor Mtor inhibitor that is already approved in combination with exemestane and aromasin. So that would be a common second-line option that clinicians may choose. And third line, again, we don't have great options defined. However, now with the SOLAR data, if a patient is PIK3CA mutated and the drug is subsequently approved, we may then pair hormone therapy with a PI3 kinase inhibitor. And always we want to consider trials. Medical oncology is rapidly changing. How we treat disease today is very different from 2 years ago, will be very different 2 years from now. So whenever a patient is newly diagnosed or comes to a fork in the road in their treatment where a decision has to be made about therapy, we pull out our trial list and see if there's a trial that the patient may be eligible for. All these drugs we're talking about that are currently approved used to be in trials. And the ones that are now in trials may become standard of care. So that's the way a patient may get access to new, exciting therapeutic options. At the end of the day, with hormone receptor-positive stage 4 breast cancer, we want to maximize the effect and duration of hormone-based therapy. When I was back in training, we treated this demographic with chemotherapy frequently. First line, you've got liver metastases. That needs aggressive therapy. We'll give you chemotherapy. We don't do that anymore. We do in rare cases if someone has what we call visceral crisis. They show up, their tumor burden is really high. They have abnormal labs. Their tumor burden in their lung may be high. They're on oxygen. We need a quick response. Not that these therapies aren't quick, but chemotherapy could be a little bit more rapid in onset. But most patients are not in visceral crisis. So we don't expose patients to chemotherapy in the first line, maybe not even the second line. And again, the goal is to maximize that sequential hormone exposure. And then eventually, again, knowing that we can't cure the setting, eventually, when the tumor is no longer hormone responsive, then we can talk chemotherapy. But that could be years. And stay tuned. Eventually, we're going to have fourth line, fifth line, and more sequential options. So that is my update as it relates to hormone receptor positive. But there's overlays in the other topics I'm going to talk about. So I apologize if you showed up to this talk thinking the title was going to be all about hormone positive disease, but I could not omit these other updates. And these updates have overlays and may be relevant as well, even to other tumor types. So let me talk about HER2 updates. And the trials we're going to talk about are the Affinity Trial, which looks at adding Perjeta. I'll show you pictures about what these drugs are, which is an antibody to standard antibody therapy, Herceptin, for 1 year in the early stage setting. The Extenet trial, which then said, after you finish your year of Herceptin plus minus Perjeta, is there merit to treat with another HER2-directed therapy called neratinib, which is oral. And then Kathryn, which is super exciting, that is in patients who have preoperative therapy and then go to surgery and don't have a pathologic complete response, PCR. That means they go to surgery and they have leftover disease. They did not achieve a PCR versus the converse of that, tumor is all gone, which would be a PCR. So in those patients who do not achieve a PCR, we'll talk about they're at higher risk to recur. And now we have data from Kathryn showing that if we switch to a different drug, Kadcyla, that outcomes are improved. So a ton of exciting data in the HER2 space that I could not omit when I'm talking about new developing targeted therapies. A quick slide on what is HER2. Think of it as a different pathway that is overexpressed in 20% of breast cancers. So here is the cancer cell, and here are the HER2 receptors on the surface that are overexpressed or overamplified in 20% of breast cancers. Again, an opportunity to block that because when you activate those receptors, it leads to a signal to the nucleus that says grow. So again, the concept of a fertilizer or growth pathway. We have had for years the luxury of Herceptin, which is an antibody. I always tell my patients we draw antibodies like a Y in medicine. So there's the Herceptin antibody binding to the HER2 receptor and blunting that pathway activation. Very effective. And we're going to talk about Perjeta and new strategies here in just a minute. So these data came out, I think when I was back in my fellowship, that showed that if you add Herceptin, which is that antibody that binds to the HER2, to this patient population who has early stage breast cancer that's HER2 positive, you reduce the odds of recurrence by around 40 to 50%. That is huge. If you read older data about HER2 positive breast cancer and how it behaves, you're going to come across phrases that say higher risk, don't have good targeted therapies. Well, that's old data, old reference. Herceptin was huge. Again, in oncology, when we have an inroad that drops the risk of recurrence by 40 to 50%, huge. So it became standard then to treat patients after they've received appropriate chemotherapy for their HER2 positive breast cancer to then treat with a year of Herceptin based upon these data. Unfortunately, though, when you look at outcomes in those patients who treat in that fashion with a year of Herceptin, we're still seeing on average about 1 in 4 women still recurring, despite chemotherapy, despite the year of Herceptin. So we've learned that it's not as simple as that one-way street that I showed you. So here is the HER family, which stands for human epidermal growth factor receptor. We know all about HER2, that's what I've been talking about, but we know there's also a HER1, otherwise known as EGFR. You hear about that in other tumor types. And we have agents that block that for lung cancer, for example. And there's a HER3, and there's a HER4. So back to the same concept I've been saying over and over. If you block HER2, that can be very effective, but then maybe there can be alternate routes that lead to escape strategies that the tumor then can proliferate from, as shown here. So what happens is, in order to send a signal of growth to the nucleus, one of these receptors has to pair with another one. So a HER2 combined to a HER2, a HER1 combined to a HER3, et cetera. And once they dimerize, that activates the signal. So you want to blockade that. And you can imagine, if you're blocking just HER2, that other partnering can be taking place. So possible points of blockade are listed here. So you've already heard about Herceptin, which is otherwise known as trastuzumab. Here's the antibody that combined to the HER2 receptor on the outside of the cell. And then we're going to talk about pertuzumab, or Perjeta, is another antibody that combined on the outside. That actually prevents HER2 from talking to HER3, which is the most potent dimerized combination. And then we're going to talk about neratinib. That works in a different location down here. There's a switch. In addition to possible blockade on the outside, once that receptor is activated, there's a switch on the inside that we can attempt to turn off, and that's what neratinib does. And then we're going to talk about TDM1 or Kadcyla, which actually is Herceptin with a chemotherapy attached to it, which is totally cool because it's like missile bomb chemotherapy delivery. So the unmet need is 25% of women still recur with traditional chemotherapy 1 year of Herceptin. We talked about the escape mechanisms. Can we improve? And Perjeta is one inroad to that. As I already referenced, when you pair HER2 with HER3, that is the most potent signal to the cell. So it makes sense. What if we block that communication between HER2 and HER3? Exactly what Perjeta does. So here to orient you is HER2 receptor. Here's the HER3 receptor. Here's Herceptin, which binds and blocks the HER2, but we know then HER2 can talk to HER3. We're going to block that with Perjeta. So the concept in the pairing of Herceptin and Perjeta is a dual HER blockade that may be more effective. So that restates what I just said, that Perjeta blocks the alternate HER2, HER3 pathway activation. And what we showed in a preoperative trial set is that if you treat with chemotherapy, Herceptin, and Perjeta, so now a dual HER antibody blockade, we improved on achieving no tumor left behind, or PCR, from 30% or so up to 60+%. That's important because we know that people who achieve a PCR do better with lower rates of recurrence. Based upon that data, the FDA approved the utilization of Perjeta in the preoperative setting, so we started to use it preoperatively. Then the question became, but what if we continue it for a year after surgery, after completion of chemotherapy, or if a patient did not receive preoperative Perjeta, we treat for a year. And that's what the Affinity Trial did. And so this schema simply shows that patients have appropriate therapy, they've had surgery, they've had their chemotherapy, and now they're going to be randomized to a year of Herceptin, which was the standard. Remember, that dropped risk of recurrence by 40 to 50%. Or they're going to get the combination of the two antibodies, Herceptin and Perjeta. And the combination showed that there was an 18% reduction in the risk of recurrence. Remember, all these inroads add up. So that now has become a standard that if we're treating patients with HER2-directed therapy, and it has to be a reasonable size, above 2 centimeters, let's say, or node positive, then we are typically pairing the two antibodies. And again, the story is not so simple. So we think we're smart. Okay, we blocked HER2, and now we blocked HER3. But, as I referenced, there's a HER1 and there's a HER4. And the dual blockade with the antibodies out here with Herceptin and Perjeta may not offer a complete blockade. Enter neratinib. Nerlinx, otherwise known as neratinib, is an oral agent that works at a different site at that inside switch that I referenced, and it binds at that switch and shuts it off at HER1, HER2, and HER4. So it is a more comprehensive, irreversible, it binds on the inside of the cell, HER signaling blockade that's HER1, 2, and 4. So it works differently at a different location, more comprehensively. So the Extenet trial said, again, nodding back to that data that 25% of women recur with standard chemotherapy and a year's worth of Herceptin. The Nerlinx trial said, the Extenet trial said, what if we pair or treat patients with neratinib for 1 year orally after they finish their 1 year of Herceptin? Okay, so they would have had appropriate therapy and a year's worth of Herceptin, and then randomized to nothing more, because that was the standard, versus another year, in this case with oral therapy, with neratinib. And that data showed at 5-year follow-up a 27% reduction in the risk of recurrence. Another inroad, okay? What makes the data kind of complicated and makes it confusing as to what to do is, as this trial was going on, the Affinity Trial was going on. So notice in my prior slide that there's no reference to Perjeta, because at the time this was developed, Perjeta was not approved. Likewise, in the Perjeta data set, neratinib isn't referenced. So that's exciting because things are rapidly changing, but it makes it a little bit more complicated for the clinician to say, how do I assimilate all this data and decide what's appropriate, knowing that we have, in many cases, clinical scenarios that the patient does not reflect the exact eligibility criteria of the trial data set. So now this is the Kathryn Trial data. So usually if someone is HER2 positive and their tumor is large enough and or node positive to warrant therapy preoperatively, and they get chemotherapy, Herceptin, and let's say Perjeta, they go to surgery and they do not achieve a PCR. The standard of care would be to continue Herceptin, Perjeta for a year, right? And now based upon the Extenet trial, maybe add neratinib after that. But is it appropriate or optimal to just do more of the same, continue that Herceptin and Perjeta for a year when they did not have complete tumor kill with that exposure preoperatively, or can we do something better? So that was the spirit of the Kathryn trial. To set the stage, and I find these graphs sobering, I share them with patients, but this is what we have to have on our forebrain when a patient is HER2 positive and has preoperative therapy and does not have a PCR. We have data that shows, and it's hard to read here, but these are two different graphs. This one is hormone receptor negative. This one is hormone receptor positive. They're all HER2 positive, so they can behave differently. Typically, hormone receptor negative patients across the board have more aggressive disease and higher risk, which explains the graphs here. But these graphs, the blue line up at the top shows what happens over time if a patient has a PCR, has complete tumor kill. And the red line is what happens in a population if they do not have a PCR. And over here, this is event-free survival, which means you want to be on the top of the curve. You don't want to have an event. So to interpret the graphs for you, again, hard to read, is if a patient does not achieve a pathologic complete response to appropriate preoperative chemotherapy and Herceptin, Perjeta, their event rate of having a recurrence can be in the range of 20-ish to 40%. So then we say to ourselves, let's do more of the same. Maybe not. Maybe we can improve upon that. That was, again, the spirit of the Kathryn trial out of San Antonio in December. Huge data. Let me explain what Kadcyla is. This is really cool. It's the first time they have combined an antibody with a chemotherapy. So it's a chemotherapy antibody conjugate. So to orient you here, this Y is Herceptin. What they've developed is a link with 3 chemotherapy elements on each Herceptin antibody. The chemotherapy is called emtansine. Emtansine is 400 times more potent than Taxol. Taxol is a common chemotherapy drug that we use, that we give into the vein or into the port, and it just kind of circulates, and as we know, chemotherapy is more cannonball. I use the analogy of cannonball versus missile, because the cannonball just kind of interrupts anything rapidly dividing. Tumor cells, but also normal cells, okay? We cannot give emtansine by itself into the vein. It would be too toxic. But if you link it to a missile, in this case, Herceptin, it then binds to the receptor, the HER2 receptor, and then the chemotherapy is deposited. So it's missile bomb chemotherapy delivery. Very cool. I'm not going to restate that. This was the general rationale behind the Kathryn trial design. And I will tell you that the Kadcyla had already been approved in the stage 4 setting. Remember, the general approach is try something in stage 4. If it's effective, which it was approved. We were using and continue to use Kadcyla in the stage 4 setting for HER2-positive breast cancer. The question is, can we use it in early stage? And this is the Kathryn trial design. What happened was all these patients had appropriate preoperative therapy, chemotherapy, Herceptin. Some had Perjeta, not a whole lot, because again, the trials were kind of concurrently under design. And they were randomized to receive more of the same, Herceptin plus minus Perjeta for the year, or switch to missile bomb, Kadcyla, based upon the premise of how it works and doing something different, because this was not optimal and did not achieve a PCR, and the knowledge that we had effective data in the stage 4 setting. Huge outcome, invasive disease-free survival, and we saw a 50% reduction in the risk of recurrence. Again, huge, huge. So when I came back from San Antonio in December, this was my conversation with patients that Monday, and several patients actually that week. So I'll summarize here in a few minutes before I give my little diatribe. What's really important, and I think not all providers may be aware of, unless they really tease out the data, is they looked at who benefited. Did you have to have a lot of disease left over, or even just a little bit? So this is called a forest plot, where they look at subsets, and I want to draw your eye to this line here. This line says if you had small volume disease left over, under a centimeter, as low as a few millimeters, that group called T1A, T1B, under a centimeter, had a 40% reduction in the risk of recurrence, even with small volume disease. So we should not use the rationale, which sometimes we do, oh, you had a really good response. You didn't achieve a PCR, but it was really robust. You went from 4 centimeters down to 0.8. That is really good. But you cannot ignore these data. That switching then to Kadcyla still is very impactful, with an additional 40% risk of recurrence, a 40% reduction in the risk of recurrence. And that point, I think, needs to be spread, because I'm not convinced everyone's aware of that. So at San Antonio, Dr. Weiner from Harvard, I think he's at Harvard, he's out east, gave a summary and said that TDM1 Kadcyla should be recommended to the vast majority of patients with residual disease after appropriate preoperative therapy. So where, do you like the little her buried there? Where do we go from here? It's changing rapidly, which makes it complicated but exciting. So an early stage, typically, again, if the tumor is above 2 centimeters or node positive, we're treating with preoperative therapy, which will include Herceptin and Perjeta. Then the patient goes to surgery. If they achieve a PCR, great. Those patients have a much better outcome, and continuing the H and the P for a year is probably reasonable, and then maybe consider neratinib. So again, neratinib was not based upon, the responsiveness to neratinib was not based upon whether or not someone achieved a PCR, because it was not a preoperative trial. So it's up to the clinician to decide, based upon baseline features, even though the patient may have achieved a PCR, whether a conversation regarding adding neratinib thereafter would be reasonable. If a patient does not achieve a PCR, then based upon the Kathryn data, nearly all patients should be switched to Kadcyla, which is a similar schedule as Herceptin Perjeta, which is IV every 3 weeks, but it's for 14 cycles, so that's like 10.5 months. And I tell patients, you're not going to feel like you're on chemotherapy for an additional 10.5 months. Even though it is a chemotherapy conjugate, it's missile bomb, and patients tolerate it very well and don't feel like they're on traditional chemotherapy. And then also in that group, maybe even more interest in considering neratinib. That's all early stage. Remember, we're trying to make inroads into that 25% that potentially still recur with the old approach. With advanced stage, up front, we typically treat with chemotherapy, Herceptin Perjeta. Once they have an appropriate response, we then peel off the chemotherapy and continue maintenance, Herceptin Perjeta. At some point upon progression, that's where I referenced Kadcyla is already approved, and we would then typically integrate Kadcyla, and that starts to remind me there are a host of other drugs in development as well for targeted HER2-directed strategies. Am I on time? Doing pretty good? Okay. Another exciting thing out of San Antonio, and this has overlays even for hormone receptor positive because this will eventually be studied in all subsets. It's immunotherapy. So this is the Impassioned Trial, which evaluated triple-negative breast cancer. Remember, we call it that because we have nothing targeted for it. It is more aggressive, higher risk with no discovered targets. Again, we'll call it something different someday when we identify targets. And the question was, could we optimize outcomes if we pair chemotherapy, which is all we have for triple-negative breast cancer, with immunotherapy? We've been trying immunotherapy for years in breast cancer and have not had a really solid inroad. Immunotherapy is approved for other tumor types, lung cancer, kidney cancer, melanoma, for example, but we've been trying in breast, but haven't had a signal of success until Impassion. I'm going to oversimplify this concept. It's really more complicated, but just to send a message, think of the immunotherapy, think of the immune system and tumor interaction as follows. So here's a tumor cell, and here is an immune cell. Our immune system, its role is to identify foreign things, bacteria, viruses, tumor, and attack it, get rid of it, okay? So it's equipped to do that. The tumor's job is to mutate, become resistant, grow and spread. So one way that the immune system seeks out and can see the tumor cell is a radar. In this picture, let's call it PD-1. Okay? And that allows the immune system to see the tumor, so to speak. Tumors, over time, may develop a resistance mechanism or ability to block that visibility by a lock and key mechanism. In this drawing, let's call it PD-L1. So if PD-L1 interacts with PD-1, the immune system is blind or less equipped to see the tumor. So it then lends the question, what if we develop a therapeutic strategy that disengages that PD-1, PD-L1 interaction? And there are a host of drugs approved and under study called anti-PD-1 and anti-PD-L1. That's kind of an oversimplification, but that sets the stage for what the Impassioned Trial studied. So this is the Impassioned Trial. I'll jump to the schema. We already kind of referenced what triple-negative breast cancer, it's higher risk, and there are no targeted therapies, and first line typically consists of chemotherapy. So this is stage 4 disease. We can't use hormone therapy. We can't use HER2-directed therapy. We don't have a target. So all we got is traditional chemotherapy. And the mantra in stage 4 breast cancer is typically sequential single-agent chemotherapy. You try drug A, eventually drug B, drug C. And in this case, in a trial, they selected nab-paclitaxel, otherwise known as Abraxane. They said that will be the standard arm, and let's compare that to the combination of Abraxane, nab-paclitaxel with atezolizumab, which is a PD-L1 inhibitor. Back to my drawing. It's an antibody that disrupts that PD-1, PD-L1 interaction allowing then the immune system to see the cancer and participate in managing the tumor. Make sense? So, this slide is simply to remind us where breast cancer likes to spread. So in the trial, we had a typical spectrum of metastases to the lung, bone, liver, and lesser brain. Here's the take-home slide. When they analyzed the data, they found that the benefit of the combination was only apparent if there was a test run on the tumor environment, that showed PD-L1 positivity. So there's a test we can run to assess for that. And if PD-L1 positivity is identified, then we saw a definite improvement or benefit with the combination, comparing chemotherapy alone to the combination of the chemotherapy and atezolizumab. This looks at 1-year progression-free survival improved from 16% to 29%. Again, limited to the PD-L1 positive tumors. Survival data are not yet mature to comment specifically, but we're already getting a signal of improvement in survival, looking at 2-year survival of 37% to 54%. That's huge. This is a disease that typically is not very responsive and more aggressive. And at 2 years, we're seeing improvement from 37% to 54% in survivorship. This slide shows us that in this particular study, when they did the PD-L1 testing, it was seen in 41% of tumors. So in order to be considered for this therapy, the doctor has to order a PD-L1 test on the tumor, and if it's positive, and there's a 41% odd it will be positive, then this would be a reasonable consideration. I think it was just last week the FDA approved the combination. The trial was a first-line trial, which means stage 4 breast cancer, no treatment yet for stage 4 disease. The way the FDA language states is it does not comment on line of therapy. So I had a patient this last week who's already had 2 lines of chemotherapy. I'm going to offer her this as 3rd line, even though it was really only studied in 1st line, but the data are so intriguing that we'd want to offer this to patients because it may not be line specific. Whether other endorsements will support other lines of or later lines of therapy or settings, we'll have to wait and see. So I just show this slide because I hear this question all the time in clinic because we see ads on TV every night about immunotherapy, and patients say, I want that. That sounds natural. That sounds new age, and it will have no side effects. Not completely true. It is new age, it's exciting, and it's equipping our immune system, but there are side effects with immune therapy. The main ones I want to point out are there are rare episodes of an overactivation of the immune system. Remember, we're trying to activate the immune system to see the tumor, but in some cases it may overactivate. You don't want that either. We have that naturally sometimes called autoimmune diseases. So in this case, there are rare cases, typically under 10 to 15%, of an immune reaction in the lungs called a pneumonitis, or in the liver, a hepatitis, or in the, I'm almost done, Jen, or in the colon, a colitis. So we have to be aware of that, and we have to monitor and test certain things, and potentially it may require stopping the drug or treating with steroids. So again, it's not completely benign. I think I'm almost done. So the conclusions were there was a 38% reduction in the odds of progression, and it was limited to the 41% who are PD-L1 positive, and again, recently FDA approved. Oh, I have to go kind of fast. I forgot I had the Parp here. So I can do this quickly. What is Parp? It is an enzyme in the cell called poly-ADP ribose polymerase. It plays a role in DNA damage or repairing damaged DNA. People who are BRCA positive, that genetic mutation, those proteins also play a role in DNA repair, and drugs that inhibit the Parp inhibit the repair of the DNA damage. So let me show you a picture, it'll make more sense. So here's our DNA, and chemotherapy purposely damages DNA because we're trying to kill the cells. Oh. Your body's Parp its job is to go in and clean up DNA damage. But if you inhibit that, it may improve the outcomes of the therapeutic intent, which is to kill a cell, because you don't want your body's own cleanup mechanism to undo what the chemotherapy or other drug was trying to do. So let's speed up here. I'm going to show you two quick trials that looked at Parp inhibitors in stage 4 breast cancer, BRCA positive, the Olympiad trial, and I'll show you another one here in just a second, but this one showed what they compared was standard chemotherapy to a Parp inhibitor. In this case, Olympiad was looking at Aliparib. And it showed that the pill was more effective than chemotherapy. Who would not want to take a pill instead of chemotherapy? And improved the progression-free survival from 4.2 months to 7 months. The BRCA trial, a different Parp inhibitor, Talazoparib, also similar trial design, looked at chemotherapy versus the Parp inhibitor. And it likewise showed improvement superior to chemotherapy with a PFS improvement from 5.6 months to 8.6 months. What we don't know and what we're still learning is, should we use Parp inhibitors only in BRCA-positive patients? Because there's a signal that triple-negative patients may benefit. So we're exploring that in ongoing trials. What about early-stage disease? I have patients now on early-stage Parp inhibitor trials. They're not approved in that setting, but remember back to my comment. If it works in stage 4, maybe try early stage. We have a trial right now looking at preoperative neoadjuvant Parp inhibition, no chemo, in a triple-negative tumor that historically would get chemotherapy. So that's novel and intriguing. Should we pair it with chemotherapy, or is it better by itself? Long-term effects, ongoing trials, so exciting stuff, but a lot of unanswered questions to date. And I'll be done in 30 seconds. The androgen receptor. Think of that as the parallel pathway in prostate cancer. So we use similar androgen receptor blockade strategies in prostate cancer as we do in breast cancer for the estrogen pathway. However, the AR pathway is seen in 70% of breast cancers. So what if we paired hormone therapy with AR therapy, or if they're triple negative, which is the main venue that this has been explored, can we have a result? And enzalutamide is one of those drugs that's under study, and it's largely been looked at in the triple negative subset, and stay tuned on those evolving data. And it's also being explored, being partnered with other drugs, and maybe another option. So I'm wrapping up here. It is complicated, way more complicated than we think. And another thing I'll just throw out is when you do a biopsy, you take a small piece of that tumor. You assume that that biopsy represents the whole tumor. Well, we know there's tumor heterogeneity. And when tumors spread from breast to node or elsewhere, they can mutate and change. So again, it's complicated. Just because we take a biopsy and we say, oh, it's got this, this, and this, and therefore this, this, and this should work, that may not reflect the biology of the entire tumor burden. So with that daunting note, I want to end on a positive note that we're making huge progress, and recently lots of progress. The current mantra is identify dominant mutated pathways, develop reliable prognostic biomarkers, and develop targeted, effective therapeutics. And as we tailor our naming and individualize management with targeted strategies, we'll observe improved outcomes with lesser toxicity. That's the entire goal. We want to treat the tumor and spare the patient any toxicity, ideally. And I think this is my final slide. This is just a sampling. I pulled it from our recent list of our trials, Encompass Oncology. We're part of a national network called US Oncology, so we have a very robust trial pipeline, and these terms and names now are familiar to you. These are just a sampling of trials that we have open. This is an immunotherapy trial. It's using pembrolizumab, which is kind of like atezolizumab in the space of immune therapy, using that preoperatively. And then here's that preoperative Parp inhibitor that I referenced. We have that trial open, and then here's that high-risk Cdk4 Six drug being studied in the hormone receptor-positive patients. So this is a sampling, and the trial lists are always changing. And that's it. Thank you.
If any of you guys have any questions, go ahead and just write them down on your comment card, and then the gals will be by in the audience to pick it up, and then we'll have Dr. Andersen answer those. And then if there's any from the simulcast site, I know that you're going to write those down for us too. And thank you so much, Dr. Andersen, for being here. That was, as always, awesome.
Okay, so we'll see how many questions we can get through. This one says, how do you choose between using neratinib, remember that's the oral HER2-directed agent that works on the inside of the cell, versus Kadcyla? Well, the schemas are different. So neratinib, the indication is after a year's worth of Herceptin, maybe Perjeta, then if they're high enough risk, you would consider neratinib for a year. So that's kind of the sphere or space for that. Kadcyla is approved already in the stage 4 setting, and based upon the Kathryn Trial data, will likely be the plan for patients who do not achieve a pathologic complete response to standard therapy. Maybe embedded in that question is would you use both? And you could potentially. Remember, these trials were developed kind of concurrently, so they may not include other developing drugs that eventually had positive data. So for example, if someone had appropriate pre-op therapy, including Herceptin Perjeta, they then go to surgery, they do not achieve a PCR, you switch them to Kadcyla. At the end of the Kadcyla, which is the 14 treatments, you would have the option to treat with neratinib if you thought the patient was high enough risk. Were there any patients in the neratinib trial who received Kadcyla? No, because the trials were going on kind of concurrently or sequentially and they weren't included in the schema. So that's where we have to make some assumptions and extrapolations. And this question was, is there a difference between the Cdk4 Six Inhibitors? So there are 3 of them as I referenced. I would say that depending upon who you speak to and how you tease out the data, there are some nuanced differences between them. 2 of them, for example, you have to take 21 days on and have a 7-day break. 1 of them you take continuously. So whether you view that as a positive or a negative, that's up to personal interpretation. There are some nuanced differences in side effects. 1 may cause a little bit more diarrhea. 1 may potentially have a signal of having penetration into the blood-brain barrier. But I think for now, they're viewed relatively similar until we have more clear trial data that specifically calls out definite differences. The follow-up question to that was, did it depend on how high the ER/PR was? And that's a good question. So we've known historically that when you test the tumor, on the report it'll say ER 100%, PR 100%, or ER 10%. PR 0. We know that with traditional hormone therapy, tamoxifen, aromatase inhibitors, usually the robustness of response is linked to the degree of positivity. So if a tumor is 100-100, I think they're going to have a more robust response to standard hormone therapy versus someone who's 10-10. Okay? We do not see that signal with the Cdk4 Sixes. In other words, the benefit that we saw across all the trials seems to be not related to the ER/PR positivity, which was intriguing data. Okay, let's see what else we got. How do you know if you have a PCR? That is determined at the time of surgery. So a patient has pre-op therapy, they go to surgery, the surgeon removes the tumor area, tumor bed, maybe samples nodes, and the pathologist will then report on their report whether there's tumor left behind or not. So in the report, if it says no viable tumor, that would be a PCR. So we don't know until we get that report back. Let's see. Are there options for HER2 positive cancer survivors that are 5 years out? So I presume we're talking about early stage patients who completed their therapy, they're now 5 years out, and can they have these treatments now, 5 years out? And the answer would be no. I'm not aware of any data that would apply to that scenario. The good news is, if someone is 5 years out, that's cause for celebration because In general, HER2-positive breast cancer tends to be higher risk, so if a woman is going to recur, it usually will happen sooner rather than later. So I'm not aware of anyone talking about data or indication to then call people back 5 years later and invite them back in. Now, I will tell you that we have to make decisions in our clinic all the time about lesser time frames than 5 years. Let's say a patient is 6 months into their HP and they had a lot of leftover disease. Am I going to talk to them about switching to Kadcyla? I am. Even though in the trial that's not how it was done. You had to be randomized to ongoing HP or Kadcyla at the time of completion of surgery. So I think most of us will extrapolate to an extent, but not out to 5 years. I'm trying to pre-read to see which ones are most appropriate for a general audience. In a young survivor who is stage 1 or 2 hormone receptor positive, would you add anything further than, for example, letrozole or just single agent hormone therapy? And the answer is, if they're postmenopausal, no. We would just do single agent aromatase inhibitor, for example, unless they enrolled in a trial that would also pair a Cdk4 Six inhibitor. Now, if they're premenopausal, then we typically have a conversation if they're high enough risk to talk about ovarian suppression. If their periods persist, then switching from tamoxifen, the standard drug in the premenopausal subset, to an aromatase inhibitor. There's trial data, which I did not cover today, from the SOFT trial that shows that combination would be better than just tamoxifen, for example. But in the postmenopausal patient, hormone by itself would be the current standard of care until we have trial data that suggests otherwise. Okay, do we have more time? Data on efficacy of hormone therapy, specifically aromatase inhibitor therapy after 10 years. So one topic I did not cover today, which I know is a constant question, is how long do I take hormone therapy? And the answer is 5 years for sure, and have a conversation with your doctor thereafter, because it's complicated. I'll try to summarize. We had earlier data that showed that if you're on tamoxifen for 5 years, that a couple trials showed that 10 years was better than 5, reducing the risk of recurrence by an additional 4 to 6%. Then the aromatase inhibitor data, or standard, came out, and we started with 5 years, and now we've looked at beyond 5 in the AI subset, and the data are mixed. At San Antonio 2 years ago, there were 3 presentations, and the endpoints were very mixed. One said 5 is all you need. Another said maybe 7 or 8. Maybe in some people 10. So that's a complicated topic and we have no data beyond 10 to answer the question. So we typically don't recommend therapy beyond 10. There's no data to support that. And for a couple of reasons. Number one, we have no trial data. Number two, we know that hormone therapy has a long lingering effect. So even though I know patients get anxious when I tell them you can now stop, we tell them even though you stop today, the tissue changes and impact can linger for years, maybe even 5 years. And the odds of a dormant tumor population then coming out and surviving that far out are so low that we probably won't have a trial that looks at any therapy beyond 10 years. But the 5, 7, 8, or 10 is a complicated question. I think it's an individualized conversation with your provider, and stay tuned because hopefully more data will help clarify that. There are some tests we can use that are out there, some genomic tests that may give insight into tumor risk and ongoing therapy benefits, so you can have that conversation with your doctor. One more question. Let me see if I can find a good one. Okay, we'll end with this one because it kind of is an overlay to what we talked about. What are the outcomes for triple-positive breast cancer? Actually good. So the more targets we can identify, the more therapies we have. And I'm glad this question was asked because another thing I want to bring up related to this is the staging manual for breast cancer changed about a year or so ago. In the old days, you just looked at a chart based upon tumor size and lymph node status. That's your stage. okay? Now, it's a much more complicated chart. You look at tumor size, lymph node status, grade, which is an aggressive scale of the tumor under the microscope, grade 1, 2, or 3. So you look at grade, then you go across the chart, hormone receptor, or HER2 positive, yes or no. Then you go across to hormone receptor, positive or negative. And there's your stage. So the new staging manual includes additional marker information. And why does it do that? What's the purpose of ascribing a stage? It's to give the physician and the patient an idea of their risk. That's what stage is all about. And embedded in that is, what therapy do I need to administer to optimize outcome? The thing, my final comment, the thing I'll point out related to that is, which is I think most relevant to the triple positive, is the new staging manual has downstaged some patients. So some people who were historically stage 3 or stage 2, simply based upon tumor size and nodes, for example, if they're triple positive and they can drop risk with HER2-directed therapy and hormone therapy, they may now be a stage 2 or a 1. So occasionally, I have a patient who I say, okay, you have a triple positive tumor, long conversation, warrants probably chemotherapy, warrants HER2-directed therapy and hormone therapy, and then the patient looks at their chart and says, but I'm a stage 1. And I say, you're a stage 1 because of that therapy. So the philosophy of the manual has changed. It used to be simply, what is your risk at baseline? Now the manual offers a stage based upon tumor features and therapeutic intervention, so that's the stage because of the therapy. So that's actually a positive thing. So being triple positive in some ways is a positive thing. Not only is it triple positive, but it's positive in the sense that we have therapies that can target it. The converse of that is the triple negative. Remember, it's not targetable aside from the PD-L1 Impassioned data for stage 4. On that note, I will end. Thank you for coming.